All right, everybody. So I want to give everybody a taste of what the master classes are like in my coaching program. Okay. So I'm gonna give you a little bit of taste of that. We are just actually talking about autonomic nervous system. So I want to do a overview of the autonomic nervous system for you. Then I'm gonna do a second video that's going to talk about autonomic failure and managing that under anesthesia. Because there's a lot of diagnoses that I don't think we don't think about it from the way that I'm going to present it. And it's taken me a while being out of practice to figure that out. Okay. But anyways, that'll be in the next video. But I want you to kind of just get a sense of what it is that I do, part of what I do in my master classes, in my coaching program, some of the ways that we study. I've also been helping people study for boards and whatnot. So I want to give y'all like a taste of that and also like help you, because I feel like this will be super valuable to help you as well. No matter where you're at in your anesthesia program or you're in nursing and you just want to dive a little bit deeper. Okay. And my number one rule, you guys are always going to hear me say this over and over and over again. Understand the big picture. Understand the big picture, the big concepts first, really get that. Then you won't have to do so much scrambling and so much memorizing when you understand that. It takes time to learn the nitty gritty, and you will be getting into that as farther you go into your program, studying for the C, studying for boards, all that good stuff. But if you don't understand the big picture, which I'm going to paint out for you today in this part 1 video of the autonomic nervous system, like it makes things more challenging. But when you understand this, then you're like, oh, then I can fill things in. I don't have to worry so much about memorizing everything. Okay. So I did this. This is not going to be as in-depth as I've gone, in my programs with clients, but this is essentially what I have in my program. This is essentially what I've been doing, studying with people. And I want you guys to get the value as well here too. And I will have links below if you want to look into other things that I have to offer so we can study and work together and coach and do mindset and all the things. Okay. So peripheral nervous system, right? Peripheral nervous system is like the big boy. Okay. The two players, I said the players in the peripheral nervous system game are going to be acetylcholine and norepinephrine. All right. So my first thing I would do is I would understand acetylcholine, how that works, how it's made, all that good stuff. And then I would work on understanding norepinephrine. Okay. And there's like a norepinephrine kind of pathway with tyrosine and how it's released, how it's the reuptake of norepi, how it's made, all that good stuff. Okay. So I'd kind of start there with knowing that, especially if you're studying for boards and like the C. Okay. But let's like just look at a big breakdown of the huge peripheral nervous system. Okay. So the first part of the peripheral nervous system is like the somatic part. All right. So the somatic nervous system is one of the sides of your peripheral nervous system. Okay. And you have sensory and motor nerves. This is responsible for sensation and movement. Okay. So your sensory nerves are always going to move via afferent pathways. Important to know when you're studying for boards. Okay. So sensory is going to move through afferent pathways and is responsible for touch, pressure, and temperature. Okay. And then the nerves responsible for sensation in the body are your alpha alpha, alpha beta, alpha delta, and your D C fiber nerves. Okay. This is really important when you're doing spinals, when you're doing epidurals, when you're doing any type of regional, learning about these nerves, how they work, because it has a lot to do with testing. Is your spinal and is all that stuff working? Okay. So that's the sensory piece of it. The other part of the somatic is movement or motor. Now, motor action potentials, motor neurons are going to move via efferent pathways. Motor is going to be efferent, okay? And they go to skeletal muscle. They cause the release of acetylcholine, and that is therefore how we move. Now, the motor nerves are alpha alpha. So some of the nerves are mixed. They're both motor and sensory. So alpha alpha, alpha beta, and alpha gamma are going to be your motor nerves, okay? And what I did when I was in school is made like just a little chart of the nerves and what they do. And then I went through the order of which one is blocked first and how you can test your spinal and your epidural and stuff like that to make sure they're working, because your patients will lose like sensation to cold, right? Because we're blocking the somatic nerves. Sometimes your patients they're not going to be able to move their legs, or their limbs are going to feel very heavy because we're also blocking motor nerves. So that is where that application piece comes into play with the somatic side of your peripheral nervous system. Okay. So peripheral nervous system, we just talked about somatic side of it, which is sensation and movement. Now we have parasympathetic, and then we have our sympathetic. Okay. So starting over here with the parasympathetic side of the autonomic nervous system is, I want you to think these words. Whenever you think parasympathetic, cholinergic, muscarinic, nicotinic. Okay. Those are all have to do with the parasympathetic nervous system. Once again, let's break down what is happening at the big picture here. Okay. So this is going to be your neuromuscular junction right here. This is going to be your motor end plate, your postsynaptic place right. These here are nicotinic receptors. Okay. This is essentially where acetylcholine binds and we get movement. Okay. And then there's something called acetylcholinesterase, which is hanging out here in the cleft of this area. And acetylcholinesterase breaks down the acetylcholine in the cleft, right? We have to keep like moving. We have to keep kind of releasing that acetylcholine, breaking it down, releasing more, all the good stuff. So you have acetylcholinesterase out here in the cleft that breaks down acetylcholine, okay? Why the heck do we care about this? Because this is where our neuromuscular blockers work, okay? Now we've got depolarizers, neuromuscular blockers, which is succinylcholine. I'm not going to go into that in this video. I do have my drug drawer guide, which goes into all the details with that as well. But you have your depolarizer neuromuscular blockers or paralytics, which is SUCs. And then you have your non-depolarizers, which is like your ROC, your VEC, your CIS, okay? And essentially, they're non-depolarizers. They're not depolarizing or doing anything to the chemical makeup of the neuromuscular junction. They're essentially, the ROC comes over here and sits on here, and then acetylcholine can no longer bind. That's it, okay? That's how it's working at the nicotinic receptor. Now, how do we reverse these, right? So these are all the pharmacology you're going to have to understand when you're doing parasympathetic. So we have our neuromuscular blockers. Now we need to wake up our patient from surgery. Now we need to reverse them. So what do we need? I'm going to need an anti-cholinesterases medication, because essentially acetylcholinesterases, these cholinesterases are breaking down acetylcholine in the cleft. I want an anti-cholinesterase because now I want to reverse them, and I want there to be more acetylcholine here to knock my rocuronium, to knock my cis off there. So I would give an anti-cholinesterase, which for our purposes, the one we use is neostigmine. We also have Sugamadex as well that works differently, something else, but Sugamadex is amazing and way better. But anyways, you have to know this for boards and stuff anyways, and for life. So neostigmine, okay? So that's an anti-cholinesterase medication. It's going to reverse that by like an anti-cholinesterase. I don't want you here because you're breaking down my acetylcholine. So if I get rid of this, then I'm going to have more acetylcholine available to knock off my drug here. And then therefore the patient is going to be reversed, okay? Side note for those of you studying for boards, there's another anti-cholinesterase medication called physostigmine, and that is actually a treatment for myasthenia gravis. Okay, little side note there. But too much of an anti-cholinesterase drug can cause a cholinergic crisis. Okay, so just tuck that in your brain for 1 second. And our final drug over here on this side is our anticholinergics or our antimuscarinics, right? It's the same thing, right? And you have M1 through M5 are all the muscarinic receptors, okay? But essentially anticholinergics or antimuscarinics are going to be your scopolamine, your atropine, and your robenol or glycopyrrolate, which is going to be, it is one of our favorites in anesthesia land, okay? Now, these have lots of other functions, right? We give these to mostly, we know atropine and even glycopyrrolate to increase the heart rate. We also give robenol to decrease secretion. So when we're doing EGDs or any type of work in the airway, we want to minimize those secretions so patients, aren't drooling or potentially causing spasm or whatever. That's normally what we use those for. Scopolamine patch behind the ear, great for anti-nausea medication as well. But anyways, the reason this all kind of goes together is when we give one of these anticholinesterase, I always teach it's like tear gas. It's like giving someone tear gas. If you give them this, they're essentially going to be, if you give it this by themselves, they're going to be in this cholinergic crisis. They're going to be like basically just like ball of wetness, tearing up, diarrhea, peeing on themselves, completely weak, bradycardic, throwing up, like just bleh, right? So that's essentially what happens if you give this by itself. Now, these drugs also work at muscarinic receptors, okay? These anticholinesterases, which is why they are causing tear gas symptoms, or essentially a cholinergic crisis. So you have to give this reversal with an anticholinergic to mitigate those symptoms, okay? And the one we use is Robenal or glycopyrrolate, okay? Now, one more side note there. If you give too much of an anticholinergic, they can get what's called CAS, which is central anticholinergic syndrome. And essentially the way I was taught it is like, if you've got an old lady who's like bat FS crazy and freaking pack you, they could be suffering from too much anticholinergic, central anticholinergic syndrome. And lo and behold, the treatment for this is going to be to give an anticholinesterase, which the one is physostigmine, which I said treats myasthenia gravis, okay? So once again, when you can understand the big picture and all of this, then it's going to click and make sense. And then you can further like, okay, if this is a treatment for myasthenia gravis, then I can understand like the side effect profile of myasthenia gravis and stuff. Like, why would this work for that disease process? Okay. So that is how I want you guys to think about this stuff from a big picture standpoint, break it down so that you can understand, you can understand the nitty gritty stuff easier and not be so like, oh my God, I have to memorize all this stuff. Make it make sense. And last but not least, I'm not going to go too far into this. I go into this in my coaching program. I also have a whole, like a bunch of little mini master classes on this in my, oh my God, my interview bundle. Those of you studying for interviews and stuff like that. But anyways, big thing to know, sympathetic nervous system, that's, your catecholamines, right? And they're going to be G protein receptors. So these are called GPCR or G protein receptors, which is your alpha 1, alpha 2, beta 1, beta 2, dopa 1, and dopa 2. Okay. So the big thing here is these are G protein coupled receptors. So, your levofed, your epi, your dopamine, alpha 1 is going to be your phenylephrine, your neosynephrine, whatever you want to call it. When they bind to, when the drug binds to the G protein receptor, it causes an increase of CAMP, okay, which is going to cause contractility along with some other things, okay? So that's kind of what's happening at the cellular level. But like I said, your alpha 1 drug is going to be your phenylephrine. Alpha 2 drugs, now this is all of these, alpha 1, beta 1, and beta 2, and dopa 1. So alpha 1, beta 2, and dopa 1 all work postsynaptically. Okay, they all work postsynaptically. Now, dopamine 2 and alpha 2 are going to work presynaptically. Okay, and they are essentially ones. They're going to prevent norepi release. Okay, they're going to prevent it. Okay, now alpha 2 drugs are Precedex, clonidine. Okay, they're going to do the opposite. They are going to decrease CAMP as they're like a negative feedback mechanism. Like, oop, okay, we've got way too much more norepi here. We got way too much sympathetic stimulation. Let's calm this down. Alpha 2 receptor, negative feedback. We're going to decrease that norepi. We're going to decrease the CAMP. We're going to calm everything down. Okay, so Precedex or clonidine, those are going to be alpha 2 and work presynaptically, with the rest of them work postsynaptically. Okay. All right, guys, I hope that was super helpful in your big overview. Check out ANS part 2 as we're going to dive into patient stuff. Like, what does all of this stuff look like when we're giving anesthesia? What does failure in these areas look like? Autonomic failure in patients, what to look for, how to manage it, all the good stuff. Check out the next video. Questions or anything, pop them below, let me know, and I will leave links to my other things in below here. Okay, see ya.